Hello everybody. Today we are going to discuss about subarachnoid hemorrhage. We have this 75-year-old female patient who is a known case of hypertension. She came to us with severe complaint of with the chief complaint of severe headache followed by drowsiness. On arrival in ER, her pulse rate was 90, blood pressure was 185 by 182 by 90 mmHg, RR was 18, saturation was 100%. On CVS examination, S1S2 present, RS air entry equal on both sides. Per abdomen was soft, non-tender, and on CNS examination, our GCA score was E4, V5, M6. So this was the MRI brain of that patient. This was the angio, MR angio, which showed aquam aneurysm. So we have started her on injection Levipil 500 mg PD, injection Dexa 400 mg TID, injection PCM 1 gram IV every 6th hourly, injection Nimodipine 60 mg through RT every 4 hourly, then IV fluid NS at 60 ml per hour. These are the blood investigation of this patient, which was almost within the normal limit. So on 16, the patient underwent left pterional craniotomy and clipping of ecom artery aneurysm and started on injection Supasep 1.5 gram BD, injection Pantof 40 mg OD, injection Dexa 4 mg IV TID, injection PCM 1 gram TID, and injection Levipil 500 mg BD. So these are the blood investigation of this patient, which was almost in the normal range. So on 25th of January, patient developed fever. She became hypotensive, started on NORAD. So the blood culture of this patient showed Klebsiella pneumoniae, which was a carbapenem resistant enterobacter. We have sent expert Carba R, which showed NDM and OXA48 positive. And we have started her on Zavicefta Astronam along with other supportive treatment. Now we'll see what is the subarachnoid hemorrhage. Subarachnoid hemorrhage results from the bleeding into CSF field system between arachnoid and the pyometer. The treatment, complication, and prognosis varies according to the underlying cause of the hemorrhage. A ruptured cerebral aneurysm is the most common cause of non-traumatic SAH, accounting for 3% of all strokes. So SAH is the neurological emergency requiring urgent management and the intensive care unit. Improvement of functional outcome are owing to early recognition, intervention, intensive care management to limit the risk of rebleeding, consequences of cerebral vasospasm, and medical complications. So saccular aneurysm lacks the normal muscular media and elastic laminar layer, making it more vulnerable to rupture. 85% of the saccular aneurysm are located into the anterior circulation. Common sites of aneurysm, they are at the junction of anterior cerebral and anterior communicating artery, the origin of posterior communicating artery, middle cerebral artery, trifurcation, and at the top of basilar artery. 20% to 30% of patients have multiple aneurysms. Now, several connective tissue disorders like polycystic kidney disease, Marfan syndrome, Ehlers-Danlos syndrome, neurofibromatosis, and fibromuscular dysplasia, coarctation of aorta, are associated with increased incidence of intracerebral aneurysm. 7 to 20% of patients with the SAH have the first and second degree relative with intracranial aneurysm. Important risk factors include later age of onset, hypertension, cigarette smoking, alcohol consumption, amphetamine, and cocaine use. So, non-aneurysmal SAH is determined based on the failure to demonstrate demonstrate an aneurysm on initial as well as repeat imaging study or when another etiology has been identified. So the common causes include vascular malformation, traumatic SAH, cerebral amyloid angiopathy, reversible cerebral vasoconstriction syndrome. The clinical presentation are often similar to that of the aneurysmal SAH. Now this non-contrast head CT from the two different patients shows high frontoparietal non-aneurysmal SAH, feeling sulci in the localized area. Both SAH are spontaneous and repeat angiography was negative in both the cases. Some non-resomal SH can be subtle, therefore head city must be reviewed carefully, especially when there is a convincing clinical history of sudden onset of headache. Now, perimesencephalic SH refers to the collection of the blood into the subarachnoid space centered on the basal and the suprasellar cistern around the pons and midbrain. When a ruptured aneurysm cannot be identified as a cause of the bleed, this distribution of subarachnoid blood is thus known as non-aneurysmal perimesencephalic SH. It represents 5.8% of all SH and often lacks identification of specific cause and commonly follows rather benign. Now, this non-contrast head CT from the single patient with perimesencephalic SH revealed the blood into perimesencephalic and the prepontine cistern only. This patient's cerebral angiogram was repeated twice and never revealed any source of the bleeding. So, regarding clinical presentation, the sentinel hemorrhage occurs among approximately 20% of patients, and it is characterized by the headache or meningismus that lasts at least 48 hours in 70% of cases. This event is misdiagnosed in 20 to 40% as tension headache, migraine, sinusitis, viral syndrome, aseptic meningitis, or laryngeal. Evidence of warning leak must be treated with high index of suspicion because such an event precedes major hemorrhage. Neurologic and functional outcome are greatly improved if the patient is treated while neurologically intact before major hemorrhage. SH produces the severe headache, neck pain, nausea and vomiting, dizziness, diplopia, photophobia, and lethargy. At the time of rupture, 45% of patients lose consciousness and may demonstrate obtrusion palsy, reflecting the acute rise in intracranial pressure that may transiently equal or exceeds the mean arterial pressure. Early seizure after SH reflects a rise in ICP but not indicative of the site and severity of rupture. Now, clinical and radiological grading. Several clinical grading scales have been developed to assess the severity and prognosis based on the initial presentation. The grading scale developed by Hunt and Hess is useful in correlating the patient's clinical status with prognosis. Grade 1 and 2 at presentation have relatively good prognosis, and grade 3 has intermediate prognosis, and grade 4 and 5 have poor prognosis. So this Hunt and Hess scale is clinically used predominantly in United States. So we'll have a look what is this Hunt and Hess grading scale. So according to this scale, grade 1 is asymptomatic, minimal headache and slight knuckle rigidity. If grade 1 is there, then it carries the mortality of 11%. Then the grade 2 is moderate to severe headache, knuckle rigidity, no neurological deficit other than the cranial nerve palsy. It has a mortality of 26%. Grade 3 includes drowsiness, confusion, mild focal deficit. It has a mortality of 37%. Then grade 4 is stupor, moderate to severe hemiparesis. It has the mortality of 71%. Then grade 5 described as deep coma, decerebrate rigidity and moribund appearance. If this grade is there, then the mortality is 100%. So much of the world has adopted the World Federation of Neurological Surgeons scale, and the World Federation of Neurological Surgeon scale uses the combined GCS along with the clinical motor deficit to estimate the likelihood of poor outcome. Now, this World Federation of Neurological Surgeon grading scale includes, so according to this grade 1, that means there won't be any motor deficit. GCS score will be 15 and the risk of severe disability, vegetative state or death will be 13%. Then grade 2, there will be any motor deficit. GCS score will be 13 to 14 and the risk of severe disability, vegetative state or death will be 20%. Then grade 3 motor deficit will be present and GCS score will be between 13 to 14 and if grade 3 is there, then the risk of severe disability, vegetative state or death will be 42%. Then grade 4 motor deficit will be present or absent, but GCS score will be between 7 to 12 and the risk of severe disability, vegetative state and death will be 51%. Then grade 5 motor deficit will be present or absent. GCS score will be between 3 to 6 And if it is there, then the risk of mortality will be 16%. The radiological Fisher score was developed in 1981 using first generation head CT to estimate the risk of symptomatic vasospasm based on the blood distribution pattern on initial CT. The major disadvantage of original Fisher score were its a non-ordinal increase in the vasospasm risk, making it non-intuitive to use at bedside, as well as that it was difficult to incorporate into statistical model used in the research. Therefore, the score has been revised and validated using modern technology HCT in much larger number of the patient and is now known and routinely used as revised Fisher score. Its linear increase with the vasospasm risk is based on SH clot thickness and the presence or absence of intraventricular hemorrhage. It is the radiological score in current use. So we'll see what is modified Fisher scale. So according to this, grade 1 means there won't be any IVH, and their SH characteristic on CT head scan will be like there will be localized thin or it will be localized thin or diffusely present, but rim will be thin. Then if it is there, then the risk of vasospasm will be for 24%. If IVH is present but absent or localized, thin or diffusely present thin, then risk of vasospasm will be 33%. If IVH is negative, but this SH will, if SH is localized or diffusely present, and if it is the thick rim is there, then also the risk of vasospasm is 33%. And grade 4 means IVH is also present, and the risk, this SH on the CT will be present as thick, localized, or diffuse thick rim will be there. Then the risk of symptomatic vasospasm will be 40%. Now, diagnostic evaluation. When SH is suspected, the urgent non-contrast head CT should be obtained to identify, localize, and quantify the hemorrhage. The sensitivity of non-contrast CT head reaches almost 100% in first 6 to 12 hours and remains over 90% sensitive at 24 hours when interpreted by experienced physician. The sensitivity progressively declined with time to around 50% at day 5. When non-contrast CT head is the non-diagnostic and clinical suspicion of SH remains high, then the urgent lumbar puncture is indicated. The diagnostic finding is xanthochromia, that is yellowish appearance of CSF following centrifugation. This is the result of blood product degradation that is detected more than or equal to 2 hours after onset of SH and is remained detected in the CSF for up to 2 weeks. Protein may be elevated and glucose may be slightly depressed. Opening pressure at the time of lumbar puncture may reflect the elevation of IC. CT angiogram is the preferred non-invasive study to identify an aneurysm in the emergent setting with sensitivities and the specificities nearing over 98%. Then the magnetic resonance angiogram can be particularly helpful to diagnose SH several days after symptom onset when head CT may be negative. MRI is less readily available and is more time consuming. Then four vessel cerebral angiography remains gold standard and is necessary to localize the lesion, assess vasospasm and possible presence of the multiple veins. It should be performed as soon as possible after initial hemorrhage because endovascular treatment can commonly be provided simultaneously. If angiography does not reveal any aneurysm, then angiography may be repeated in 3 to 7 weeks as intraluminal thrombus and extraluminal compression of small aneurysm by subarachnoid clot can acutely interfere with angiographic visualization of aneurysms. Now, this is the 3D reconstruction of large anterior communicating artery aneurysm. The advantage of 3D reconstruction technique include high resolution view of aneurysm to visualize smaller penetrating arteries coming off the aneurysm versus parent vessel, as well as the ability to visualize small aneurysm and infundibulum-like outpouch. Without 3D reconstruction, this could be potentially missed. So this diagram shows the cerebral angiography of same patient, which reveals the anterior communicating artery aneurysm, pre-coil and post-coil. After coiling, the aneurysm no longer fills. Although it appears there may be filling defect, it merely the coil mass overlying the parent vessel in the anterior posterior 2D. Now we'll see how to manage aneurysm. So subarachnoid hemorrhage is immediately fatal for 12% of cases, while the 28-day mortality is 35%. In-hospital mortality is 18%. The high mortality is due to further complications, including rebleeding, delayed vasospasm causing infarction, hydrocephalus, increased ICP, seizure, and medical complications such as myocardial infarction, stress cardiomyopathy, and neurogenic pulmonary edema. After SH, the initial goal of treatment are aimed at identification and early aneurysm treatment by either coiling or clipping. The International Subarachnoid Aneurysmal Trial, that is ISAT trial, concluded that the patient receiving independent at 10 years compared to the patient have undergone surgical clipping with very low increased risk of rebleeding deemed not to outweigh the benefit. On downside of the coiling is the higher aneurysmal recurrence rate on follow-up angiogram 6 months or longer after initial coiling, sometimes requiring repeat coiling. Based on ISAT, the endovascular treatment of intracranial aneurysm rather than surgical approach uh, is now preferred treatment option, and this should ideally be accomplished as soon as possible. Now, regarding neurological complication, the rebleeding is the serious and frequent complication of subarachnoid hemorrhage. Rebleeding risk is 5.8% in first 24 hours after SAH, and it carries 57% of mortality. Clinical symptoms include sudden increase in headache, seizure, nausea, vomiting, depressed level of consciousness, and new neurological deficit. A well-recognized risk factor for rebleeding is hypertension and the fluctuation of the blood pressure. Although a relatively elevated blood pressure could promote rebleeding, a low blood pressure may diminish cerebral perfusion, especially in the setting of high IC. Prior to securing aneurysm, the systolic blood pressure should be less than 160, and that has been recommended. Blood pressure should be lowered gently and best managed with short-acting agents like nicardipine and labetal. Now, the next complication is cerebral vasospasm and delayed cerebral ischemia. Cerebral vasospasm and subsequent delayed cerebral ischemia are the major cause of morbidity and mortality post-SH. Only symptomatic but not angiographic or transcranial Doppler detect cerebral vasospasm has been associated with delayed cerebral ischemia and is therefore considered the meaningfully of cerebral vasospasm. This cerebral vasospasm is evident on transcranial Doppler for 71% of patients and by angiogram for 60% of patients, but it causes relatively evident symptom only for 36% of patients. The difference probably reflects the adequacy of collateral circulation of individual patients and the degree of vascular vessel narrowing and the involvement of less critical brain structure. Unlike rebleeding, the clinical presentation of cerebral vasospasm occurs progressively over a period of hours to days. It may be apparent as early as third day after hemorrhage, with the peak between day 4 and 12, rarely as long as 3 weeks after subarachnoid hemorrhage. Monitoring for cerebral vasospasm include frequent neurological examination, daily or every other day transcranial Doppler monitoring. Trends in the transcranial Doppler from baseline early after SAH onset are clinically useful because an elevated blood flow velocity is often detected before the occurrence of symptomatic vasospasm. Now, the disadvantage include diagnostic precision, that is operator dependent, and much lower sensitivities for vessel other than middle cerebral artery. Although calcium channel blocker nimodipine has failed to prevent cerebral vasospasm, it improves morbidity from the vasospasm and is only therapeutic agent with level 1 evidence to support its use post-SH. The current standard of care to administer prophylactically 60 mg of nimodipine orally every 4 hours for 21-day course beginning at the onset of all aneurysmal SH. And the main adverse effect is mild transient hypotension. Now, the triple H therapy, that is hypervolemic, hypertensive, and hemodilution therapy, is no longer supported by guideline, owing to the existing evidence of adverses associated with outcome after the use of hemodilution. Prior to the use of symptomatic vasospasm, maintaining the euvolemic state without prophylactically induced hypertension is now recommended. Once symptomatic vasospasm occur, then this hypertensive and hypervolemic therapy is indicated. Elevation of systemic arterial pressure produces the significant increase in regional cerebral blood flow, while optimal increase of the blood pressure or the use of systolic versus mean arterial pressure threshold is not. The intra-arterial infusion of vasodilators such as verapamil, nicardipine, midrinone, or in the refractory cases, angioplasty is another commonly used endovascular technique for the treatment of cerebral vasospasm. The patient selection criteria for treatment include presence of clinically symptomatic cerebral vasospasm without infarction in patient with the repaired aneurysm. The severity of cerebral vasospasm and subsequent ischemia appear to relate to the amount of blood in CSF space. Thus, there is increased significant interest in therapeutic drainage of bloody cells. To achieve this, ventriculostomy is commonly placed. In Europe, an additional lumbar drain is often placed, but due to lack of the large trial, this practice has not been established as a routine in United States. The experimental use of intrathecal and intraventricular urokinase or tissue plasminogen activator had suggested improved outcome and lower incidence of angiographic vasospasm and infrequent complication, although the trial thus far have been underpowered. Now, the next complication is seizure. Seizure may increase ICP and may subsequently increase the risk of rebleeding. The middle cerebral artery aneurysm and thick SH clot may increase the risk of developing seizure, which is as at 27%, and it is the highest within the first. Use of prophylactic anticonvulsants such as phenytoin or levetiracetam is indicated prior to securing aneurysm. Studies of the use of anticonvulsant, in particular phenytoin, have been associated with the worst neurological recovery, and therefore guideline recommended stopping anticonvulsant as soon as the aneurysm has been secured, as long as the patient is not comatose and has a consistent neurological examination to follow. Now, the continuation of anticonvulsant may be justified when patient had seizure at SH onset and is thought to be due to and it is thought to be at very high risk. Hydrocephalus. Now the next complication is hydrocephalus. Hydrocephalus can develop acutely within first 24 hours after SH because of the impaired CSF reabsorption, atarachnoid granulation, or presence of intraventricular clot obstructing CSF outflow. So clinically significant hydrocephalus developing subacutely over a few days or weeks after SH is manifested by impairment of vertical gaze or progressive lethargy. Now, ventricular CSF drainage is indicated when the clinical neurological examination deteriorates. Although ventriculostomy or lumbar puncture should be performed with caution for patients with unsecured aneurysm, it does not seem to be associated with the significant increased risk of reveal. A delayed form of hydrocephalus manifested by cognitive changes and gait disorder, and it may be observed several weeks after SH. In this case, the ventriculoparietal peritoneal shunt may be indicated. Now, the cardiac and pulmonary complication. Cardiac and pulmonary complication may be seen in high-grade SAH in first few days after aneurysmal rupture. Excessive sympathetic stimulation at the time of aneurysm rupture leads to cardiac dysrhythmia in 28% of SAH cases. The increased level of circulating catecholamine influences the alpha receptor of myocardium, and it can result in prolonged myofibril contraction, eventually causing myofibril degeneration and necrosis. Elevated levels of serum troponin and the brain natriuretic peptide level are common, but not due to coronary artery plaque rupture with thrombocyte activation and adhesion. So the SH is most frequent neurological cause of neurogenic electrocardiographic changes. That is a large upright T wave, inverted T wave, prolonged QT interval, prominent U wave, minor ST elevation or depression can occur. Despite STD changes, the incidence of myocardial ischemia remains low. Pathological Q wave are not common after SAH and suggest the need for further investigation for myocardial infarction. Now, the sympathetic surge also leads to stress cardiomyopathy and global compromise in cardiac left ventricular function. This usual transient cardiomyopathy is characterized by the global dysfunction, not respecting the coronary arteries vascular territory, and result in apical ballooning, giving the cardiac silhouette the shape of a Japanese octopus fishing pot, hence the name Takatsubo cardiomyopathy. In rare instances, the intra-aortic balloon pump may be indicated during transient cardiac dysfunction. Neurogenic pulmonary edema is not uncommon with high-grade SH. It is due to direct beta receptor stimulation in the lung due to sympathetic surge. This can lead to sudden and early massive increase in pulmonary lung water with severe hypoxia. Although the pulmonary edema is transient during first 24 to 48 hours, early recognition and treatment with diuretics are necessary. Now let's see what is the general ICU management. Once aneurysm has been secured, the general ICU management includes close neurological and hemodynamic monitoring, head elevation to improve cerebral venous return and prevent increased ICP, good pulmonary toilet to avoid atelectasis and pneumonia. Headache often persists for several weeks even after securing aneurysm and is due to meningeal irritation from the blood product breakdown. Pain control can be difficult and opiates are commonly required. In refractory pain, the corticosteroid, that is dexamethasone, may help improving meningitis symptoms. Now, hyponatremia is found in 30% of SH case and it is caused by hypothalamic dysfunction, sometimes causing the syndrome of causing the syndrome of inappropriate antidiuretic hormone, but much more commonly cerebral salt wasting owing to increase in circulating brain natriuretic peptide level. Serum sodium level, osmolality, as well as volume status must be followed closely. The usual treatment for SIDH is fluid restriction. However, this is contraindicated in SH because it may exacerbate cerebral vasospasm, and hypertonic saline should be used instead while maintaining U volume. Now, cerebral salt wasting syndrome is the hypovolemic hyponatremic state that respond to treatment with isotonic fluid and fludrocortisone. Now, venous thromboembolism prophylaxis should be started immediately on admission with the use of pneumatic compression boots. Although all antiplatelet and anticoagulation medication should be discontinued on admission and they should be restarted if still medically indicated along with subcutaneous fractionated and unfractionated heparin for venous thromboembolism prophylaxis as well as aneurysmic sequelae. With the decreasing platelet count, one should have high degree of clinical suspicion of heparin-induced thrombocytopenia because it affects 6% of SAH patients. Fever is a very common complication of SAH and it is associated with worse outcome. Although the fever is therefore commonly treated with the induced normothermia, one should note that no clinical trial have been conducted to show improved outcome by applying normothermia and suppressing fever. Anemia and hemoglobin concentration less than 9 grams have been associated with worse outcome as well. However, optimal hemoglobin goal levels are not known. Hyperglycemia of more than 200 mg per dl is associated with worse outcome, but should be treated with strict avoidance of hypoglycemia. Now we'll see summary of recommendation. Every identification and the repair of ruptured aneurysm by clipping or preferably when feasible by coiling is indicated to prevent rebleeding. ICU care should entail the administration of enteral nimodipine for 21 days, euvolemia, normovolemia, and blood pressure management, and adequate oxygenation and ventilation. The only clinically symptomatic cerebral vasospasm, but not transcranial Doppler or angiographic vasospasm should be treated with hypertensive or hypervolemic therapies as well as intraarterial therapies. Prophylactic hypervolemia and hypertension before the onset of symptomatic cerebral vasospasm are not indicated. Hemodilution is contraindicated after SAH, and hydrocephalus should be treated with ventricular and extraventricular CSF drainage. Anticonvulsants are only recommended prior to securing aneurysm and should be stopped as soon as possible thereafter. Cardiac and pulmonary complication can occur after high-grade SH, and aggressive supportive care is warranted throughout the acute phase as they are usually reversible and transient. Admission to high volume of SH center is recommended as improved outcome can be achieved compared to low volume center. Now we'll see the echo findings of SH. Uh, commonly known as Takotsubo cardiomyopathy. The usual pattern of abnormality is systolic wall motion abnormality that involves apical LV segment with sparing of mid and basal segment of myocardium. The apical hypokinesis may be severe with akinesis and dyskinesis of involved segment. Because of the base of the heart continues to contract, the apical dyskinesia results in pattern of apical ballooning. Because the predominant abnormality is apical in position, the abnormality may not be apparent on parasternal long axis view. The apical four-chamber and subcostal long axis view reveal the characteristic abnormality. A typical pattern of stress cardiomyopathy includes segmental wall motion abnormality involving basal and mid-ventricular myocardial segment, resulting in inverted Takotsubo pattern, where apical segment exhibits normal contractility while basal segments have reduced systolic function. Abnormalities of right ventricular function have been described as the echocardiography cannot distinguish between the stress cardiomyopathy and myocardial ischemia infarction, as both entities result in segmental wall motion abnormality. So, echocardiographic findings support the diagnosis of stress cardiomyopathy, but clinical correlation is required for definitive diagnosis. Advanced echocardiographic measurements such as diastolic functions, speckle tracking, MRI, and echocardiography reveal the characteristic abnormality but are not required for diagnosis. Goal-directed echocardiography examination is effective for identifying characteristic feature of stress cardiomyopathy. Thank you.